second.
You got it?
I think I've just clicked it, Justine. I think.
Okay, brilliant. Thank you so much. Thank you. So,
Cool.
all right. Can you hear me? You can hear
Yes,
me,
we can hear you. Yeah.
and you can see my screen.
Yes.
Perfect. Welcome, everyone. It's great to have you here with us. This is an Agile East hosted webinar, and it's about dementia and pain. And it's exciting to host our very own Adrian. I'll tell you more about him in a second. So a bit of housekeeping before we start. Please keep your microphones on mute during the session unless you're speaking. This session is going to be recorded. So if you do not wish for your face to appear, please turn the camera off. Use the chat box, please, to raise any questions or comments. Please do interact in the chat, comment on other people's comments. Let's make it an interactive session. Please keep your phones and devices on silent during the session. And yeah, if you need a drink, please do grab it. We don't want UTIs. And also, if you need any help with Zoom functionality, please do send an email to the Agile Education Officer Gmail address. So my name is Justine. I am the Agile East rep, and I am hosting this event. So welcome once again. Before we start, just quickly to say that we have vacancies on our committee, on the National Executive Committee, and also on the Agile East Committee. So please, if you're an Agile member, please do sign up to join a committee. We can always do with an extra hand. If you are not a member of Agile, you're very welcome to join us. You don't have to be a physiotherapist, and you don't have to be a member of the CSP to join Agile. And you can join, it's £15 for the whole year. So that's how many sandwiches? I don't know. So please, please do join us, and then you'll have access to all these amazing things that you can see on the screen. So I will introduce our speaker today, who is Adrian Vyse. I've said his name. Yay! We had a session where we practiced saying his name correctly. So Adrian is a clinical specialist physiotherapist who works at West Herts Teaching Hospitals, and he's going to speak to us today about dementia and pain. So if you have any questions during the session, please type in the chat or keep them for the end of the session. There's going to be a bit of Q&A time. So I will hand over now to Adrian. Adrian, over to you.
Thank you. Let me just get my slide up and running. There we go. Right. Can everyone hear me? Hopefully you can.
Oh, yeah,
It's amazing to see so many of you here this evening. This is a subject that I'm fairly passionate about, so it's really, really pleasing to see so many people joining the webinar just to learn a little bit about this. And there's way more to learn than I can cover in this session, so hopefully this will pique your interest and you can go away and begin to learn even more. We're going to try and why is my thing moving? Right, there we go. So we're going to try and understand how dementia affects the processing and expression of pain for people who are living with dementia. understand how to adapt your pain assessments and strategies for people living with dementia, and do a little bit of exploring management options for helping people manage their pain when they're living with dementia at the same time. I usually start this point by asking the audience, but I'm not expecting response to this point, but who has experienced pain? Of all of you out there on this webinar, I'm willing to place a reasonably large bet. Yeah, Beth's got her hand up. I wasn't sure if you could do responses on Zoom because I haven't done it for a while. But yeah, we've got a few hands. I'm reasonably willing to bet that most of you have experienced pain at some point in your life. If you haven't, that's quite amazing. But if you have, that makes you your own expert. So you will know all about pain, which is... Now, I once was having a conversation with a medical registrar about a patient who'd had a fractured neck of femur, who told me they don't need painkillers, they've got dementia. And I was quite staggered. Then I started looking at the research after that, and this has led down this path to this point here. There's also a study just 10 years ago where 10% of acute hospital nurses still believe that adults with dementia don't experience pain, which is still shocking. Shocked as Joey. So we start off with working through a definition of pain, and one of the kind of traditional ways of looking at it is an unpleasant sensory emotional experience associated with or resembling actual or potential tissue damage. So it's really kind of thinking of that kind of structural type pain. And that physical pain, we've all been through this before. This is really a quick bit of revision. But you have peripheral nociceptors, joint nociceptors, visceral nociceptors, and they will generate some nerve impulses that will travel up your nociceptor nerve fibers, up to your dorsal root ganglion, in your dorsal horn, up your spinal cord ascending tracts, and links to your cerebral cortex via your brainstem, like that. And it goes, ouch, and you feel pain. But I think the definition of pain has evolved a bit more over the years, and we now need to kind of encompass a more biopsychosocial model when we're looking at pain. So the evolving kind of definitions of pain tend to be linked around unpleasant sensory and emotional experiences, and that pain can't solely be inferred from those sensory neuron activity. So there are other things going on here that help, allow people to experience pain or mean that people are experiencing pain. This leads on to a slightly more recent concept of kind of total pain, and this especially becomes important when with palliative care, and a lot of palliative care teams are now looking at this kind of total pain burden of their patients. This will encompass the physical pain, the spiritual pain, the social pain, the psychological pain that someone's experiencing. And it's basically a much more holistic view of how people experience pain during their lives. And we'll kind of touch in and out some of these concepts as we work through the presentation. So how much pain is there around? Well, as I said at the beginning, I was willing to bet that most of you had experienced pain in some way or another. And it won't come as a shock that people over 65 have the highest instances of painful diseases. 20 to 46% of older people living in the community will report pain on a regular basis, and 28 to 73% of those living in care homes. Interestingly, pain prevalence increases with age up to the age of 85, but then starts to decrease, which is interesting. I'm not quite sure why that might be. You will find increased prevalence with people with raised BMIs. Interesting, lower levels of education, not sure why that is. Socioeconomic deprivation, although those two things may be slightly linked. And you will see more prevalence in women, but with men. But interestingly, the study that found that also goes on to say that women are a lot less likely to be concordant with pain relief medication than men are, which is an interesting paradox. Acute pain or worsening of chronic pain is reported for 38 to 84% of people admitted, older people admitted to hospital. And 50% of people living with dementia will report pain at some point during their dementia process. For nursing home population of people living with dementia, 60 to 80% regularly experience pain. And when we come on later to say that we're not very good at detecting pain and noticing it and recording it in people living with dementia, those rates might actually be higher than those detected in these studies, which is slightly shocking. So if we don't manage pain very well, what's the consequences? Does it really matter? Well, yeah. Decreased function leads to activity restriction, decreased social participation, poor quality of life, distress on a regular basis for people. There's evidence that suggests that especially back, neck, and lower limb pain will lead to poor balance, and that pain there is an independent risk factor for falls in older people. And you may well see exacerbation of behavioural and psychological symptoms of dementia. Those can include signs of distress, so biting, scratching, shouting, screaming, throwing things around, lots of upset. They can include things like emotional lability, from being withdrawn to being very angry and vociferous and shouting. So they're quite varied, but they can again be driven by increased pain levels in older people living with dementia. Can also find that pain can lead to delirium. It is a risk factor for developing delirium in itself. The interaction between delirium and pain is quite difficult to fully conceptualize, and sometimes delirium can lead to pain can lead to delirium, and the two things interact a bit together, which makes it quite hard as a management challenge to really get to grips with. We'll touch upon it a bit later as well in the management section, because there's a lot of debate around, again, analgesics and delirium and not having analgesia. And yeah, so it's quite a difficult interaction between delirium and dementia. And I think the best thing I can say about that is everybody is different and each case should be taken on its own merits. Significant pain can lead to delayed recovery from illness, slow rehabilitation, sleep and appetite disturbances, which are often difficult to manage, and overall will generally lead to an increased length of acute hospital stay, which is not what's wanted by anyone, because hospital's not a great place to be if you have delirium. You need to be out of delirium. Sorry, out of delirium would be lovely. Hospital, not a great place to be if you have dementia, and you need to be out of hospital living your life as much as possible, not stuck in an acute hospital bed. So I went back around all these, and I had a little look through the research there is around upon the type of dementia that you are living with and how that might affect your perception of pain and your expression of pain. And there was some research that covered this, and Alzheimer's disease, the most common one of all. Early studies have shown that your threshold for kind of detecting pain or noticing pain is unchanged, but pain tolerance might be slightly increased. They did find in the studies that they did that your autonomic responses to pain, so increased heart rate, sweating, slightly increased blood pressure, flushed face, those sorts of autonomic responses are blunted with mild pain stimuli, but they're normal if you've got a lot of pain going on, if you've got a higher level pain going on. So it's worth noting, if you've got someone with Alzheimer's disease who is showing a lot of autonomic responses that you would associate with pain, they're quite probably in quite a lot of pain, which is a bit worrying. The pain reflex studies done later on and some functional MRI studies, they've shown that the reaction of people living with Alzheimer's disease pain is more pronounced than people not living with Alzheimer's disease, especially in the context of white matter lesions in the brain. So if you've got Alzheimer's disease and your CTs show some white matter degeneration in your brain, there's a strong possibility you'll have an enhanced experience for any given pain stimulus, that you're actually going to feel more pain than someone without that dementia process going on. Quite the opposite to the perception of my medical registrar many years ago. Unshockingly, with vascular dementia, which is often characterized by these white matter lesions in the brain, they often have a very poor experience of pain. They suffer an increased experience of pain for any given stimulus. It's a thoroughly unpleasant thing to experience. There are some parallels between these deep white matter changes and how that influence your experience of pain, and some of the kind of central stroke pain syndromes you'll see on stroke units and with patients that have had large strokes or deep white matter strokes. It's a big overlap in how they experience pain. Frontotemporal dementia is fortunately fairly rare, but also does some odd things to how you will perceive and process your experience of pain. The affected areas in frontotemporal dementia relate strongly to emotional states and motivation. So your appreciation of painful stimuli might be significantly lower in frontotemporal dementia compared to other dementias and people who aren't living with dementia. But also you'll have a reduced ability to anticipate danger and to make withdrawal from danger. So these are the guys that will put their hands on something hot, go perhaps, ow, take it away, and then put it back again. So there really is a significant warning sign around people with frontotemporal dementia that they may not be experiencing the pains in a way that actually guards them from damage to themselves, which is worth factoring into your kind of overall risk assessment of what's happening with those patients. Lewy body dementia, there were no clinical trials available on Lewy body dementia. Theoretically, it will affect almost all facets of pain. And as in, you may not perceive those things as well as other people without dementia. But there haven't been any clear studies done on this. I'm not sure if there's any in process even. I haven't seen any. Fortunately, again, it's relatively less common to Alzheimer's and vascular dementia. But again, be cautious when approaching them and work out where you're going to go, because they may not be experiencing pain in the same way that you or I would anticipate. This leads us on to the assessment challenge. Assessing older people, and especially older people living with dementia, for pain is a challenge. And part of the reason is we start off with a communication gap. And through a number of studies that have been done over a number of years, there seems to be culturally assumptions among widespread health professionals, and not just physiotherapists, but nurses, doctors, OTs, across the healthcare spectrum, that pain's an acceptable part of aging. And that therefore older people should feel a bit of pain at times. At the same time, studies have shown that there are assumptions amongst older population that healthcare staff will just know when they're in pain without them having to tell us. So there we are assuming that a little bit of pain's normal for them, so we don't ask. And they're assuming that we'll know, so they don't tell. So we need to change this paradigm a little bit and make sure we're asking regularly. Pain itself, as all of you who've experienced it will know, it's a subjective symptom and we can't measure it. I can't put a pain cuff on your arm, give it a quick tweak, or stick a little probe in your ear and say you're in 7 of pain. We don't have a mechanism for doing that. So we are therefore relying on how a person communicates about their pain. And that can be influenced by their age, their gender, how much pain experiences they've had over the course of their life, social and cultural norms about what is a normal way of responding to your pain. And older people, as in the studies that have been done, often will deny they're in pain, but will respond to terms like soreness or aching or discomfort or stiffness, that's extreme stiffness almost. So they will respond to alternative terms, which is interesting. So we need to try and work those into how we're phrasing our questioning when we're talking to older people. And same for, we need to be routinely monitoring pain, assessing it, reassessing it, documenting it. And that way we can ensure that people's pain is managed and that all of the problems that I ran through earlier about the consequences of unmanaged pain are dealt with. And whenever possible, the classic line, the existence and intensity of pain are measured by the patient's self-report, and pain is whatever the experiencing person says it is, existing whenever he, she says it does, which is always the kind of gold standard way of looking at pain. It should be noted, many people living with moderate to even the beginnings of severe dementia can self-report pain reliably when they're prompted. We do need to ensure that we give them sufficient time for them to formulate a response. It can take longer for them to get the right words together to respond to you. And it's often easier for them to tell you reliably about the pain at the time they are experiencing it. There were some studies out there again showing there's up to 40% of nurses don't want to accept people with dementia self-report even when they are reporting pain themselves, which is also slightly worrying. This isn't meant to be a nurse bashing session, by the way, and my wife is a nurse, so I can get away with some of this. You can use a tool to aid that self-report, and there are lots of them around. You've probably come across lots of these before: verbal descriptor scales, pain thermometers, verbal numeric rating scales, graphic rating scales where they can just mark on it. You might have seen smiley face scales. There are lots of different ways of doing them. If your trust uses a particular one, great. If you use one in your practice, great. There's nothing wrong with them. It's better if it's consistent across your area, because that can really help when you're communicating this between team members. But those can help you get an idea of someone's kind of severity of their pain. But those tools are one-dimensional. They're just really measuring intensity. Can we do better? I think we can. I think we can do better. So there's a couple of acronyms to help us do a little bit better with our pain assessment. Socrates is one, and the next one is OLDCARTS. And again, many of you may well have come across these in your training or use these at work already, and that's great if you do. So looking at site, onset, the characterization of the pain, whether it's radiating, associated symptoms with the pain, the timing of the pain, how long it lasts, how long it takes to go away again after activity maybe, exacerbating and relieving factors, and the severity, that those perhaps marks out of 10 or moderate, mild, severe, very severe, whatever way you want to measure it. OLDCARTS works through onset, location, radiation, very similar things. Duration of your pain, the characterization of your pain, aggravating factors, relieving factors, the timing of your pain, and severity. And these things will just help that be a little bit more detail about that pain, understand a bit more about what's happening to that person and what that pain's doing for them or doing to them. But we can keep going. We can try and make sure that we include these movement-based activities in pain. Oh, there you go. So more things about nurses, sorry. But we want to understand how movement, and this, I know I'm preaching to the choir with a group of physiotherapists, but we need to understand how movement might trigger pain, how activity changes pain. Does it get better as you walk? Does it stay the same as you walk? Does it get worse as you walk? Perhaps movement reduces pain as you go along. How would we need to find out how that interacts with them, and how does that pain impact on their function? Is the pain stopping them living their life in the way they want to live their life? Is their pain preventing them from doing enough, being functional enough to return home right now? It's interesting, though, that 45% of nurses do believe that assessing pain at rest indicates whether their pain is present at other times. And I see this a lot now, day to day, at an acute hospital where I work. They say, well, they're not in any pain. Well, yeah, they're not, because they're lying absolutely stock still in bed and not moving a muscle. And then they're not in pain. But the minute they try and move or they try and do anything, then they're in pain. And then we've got problems with how we manage that. However, as your dementia progresses, the communication your ability to communicate and clearly express pain will begin to diminish. And you may well get to the point where you're expressing pain in atypical ways. There are some classic things about guarding, bracing, reduced movement, but you may also see people who will respond to, I don't know, hip pain by getting up and walking to try and escape from the pain. And they may constantly be in motion to try and get away from it. You may see people that just throw things around or get angry or become very, very quiet and withdraw. So we had one patient who would only say, oh God, oh God, oh God, oh God, oh God, repeatedly. And then their family told us if that switches to oh mum, oh mum, oh mum, oh mum, that means they're in pain. So we absolutely needed some information from the family about how to interpret their expressions into something meaningful. But these pain behaviours can often be misinterpreted as behaviour and psychological symptoms of dementia. If they're interpreted in that way, traditionally over many, many years in healthcare, and not just in this country, often the response is to start antipsychotics or increase the amount of antipsychotics that they're on, rather than looking at pain or trying an analgesic trial or trying to manage pain and seeing if that changes behaviours. And often if pain is the driver, you give pain relief and the behaviours will change radically. So it's trying to think around, is this really just BPSD that I'm seeing due to changes in their psychological well-being, or do we have a pain problem somewhere that might be driving these behaviors? Just be curious, try and understand, try and think more. The consequences of not thinking these things are pain means that the pain doesn't get treated and the person continues to suffer. Remember, going back to the beginning, that we can't rely on those physiological signs because they're not reliable in people with dementia processes for determining that they're in pain. So because of that, placing this into context, we have these atypical behaviours coming through. Figured somewhere, we're going to flick through this because I've talked about this before I got to the slides, but never mind. So we'll go down there. And then this, which person's in pain? Well, the lady with the walking stick seems to be telling us fairly clearly that perhaps her wrist is hurting here. I'm guarding it. I've got my eyes squeezed shut and I'm holding on tight. The gentleman on the left of my screen, he could be grimacing. He could be smiling or laughing. He might have some wind. It's hard to tell exactly what he might be feeling. I was looking at this the other day with one of my colleagues and I felt it looked like he's kind of laughing a bit, but they felt it looked like he's absolutely in pain. So this can be slightly tricky to try and work out who might be in pain and who might not be in pain when some of the signs can be quite subtle. The AGS, the American Geriatric Society, said there's 6 main types of behaviors and indicators for pain. The facial expression, so grimacing, tightening of the eyes, squeezing the eyes shut or wide open eyes, actually looking sad and distressed and pulling, tightening around the mouth and drooping of the mouth. There's also verbalizations, vocalizations, moaning, groaning, shouting, screaming, those sorts of things, sighing. Body movements might be protected or reduced. Body movements might not be moving at all or might be exaggerated, or you might be protecting or guarding a part of the body. You might also see changes in interpersonal reactions. They might start getting more angry, more withdrawn, very sad quickly, becoming very disconsolate and almost kind of depressed type behavior. There might be changes in activity patterns or routines, and that might be as clear as stopping walking when they could walk before, or it could be something like stopped going to classes or joining in with activities that they'd normally join in with. And there might be mental status changes. It can even affect your AMTS scores or some of the attention tests because you're distracted by that pain. So you might even begin to start scoring on 4ATs and things like that when you're in a lot of pain. So I figured there's lots of very, very clever people in the world, and someone will have constructed a nice tool that looks at these types of behaviors and can allow us to score people on these behaviors and come up with, yes, they're in pain, no, they're not in pain, and perhaps how much pain. Turns out lots and lots of people have tried. There are about 26-ish, maybe more, tools out there for assessing pain with people who have significant problems communicating. These guys, these three meta-analyses were conducted looking at those various tools, and they all come to the same conclusion that there's no standardized tool that they can recommend for broad adoption in clinical practice, which was a little bit deflating because I figured there must be something out there that would really, really work. The British Geriatric Society did recommend the AGILE pain score a number of years ago, and that may well be used around a number of trusts. And I think we have it on our electronic patient record system. It's not brilliant. It's not a great tool. The one that comes closest, according to most of these studies, and the one that involves what physiotherapists love, which is getting up and moving around and movement included in the analysis, is something called DOLA plus 2. You can see it's a fairly longish tool. I don't know how well you can see it on your screens, but hopefully you can see it there. But it does include mobility, and it does include social life, and it does include things like protective body postures and things as well. And it's not a bad tool. There's still some validation going on with it and comparing it to other studies. And similarly to a lot of these tools, you get a lot of false positive rates, which is slightly frustrating. And again, all of these tools, this one or AGILE or there's lots of them, pain ad packs, like there's loads of different tools. All of them really are only giving to give you an idea of the presence of pain, but not really the severity of that pain, which makes it quite difficult. There is a couple of things in process in study at the moment that are looking at almost like a meta tool of combinations of the best aspects of all these tools that are out there to see if they can come up with a new tool and one that can look at intensity of pain as well. So maybe in the next few years we may have a tool that is more useful than the ones that are out there at the moment. So they're quite useful. So in the absence of that holy grail of a nice tool that's going to work to tell us if someone's in pain and how much they're in pain, we fall back to being pragmatic and sensible, and as all therapists will know, we're here to bring the common sense to the situation. So we can work through this, which is a nice hierarchy of pain assessment techniques. Let's get self-report if we can get self-report. Yeah, if they can tell us, great, let's do that, but let's do it in a really good way and let's get the best self-report we can get from them. Next, we can search for potential causes of pain. If they have broken their hip, there is a strong possibility that they're in equally as much pain or more than someone without dementia that's broken their hip. So let's treat them that way. So we're going to look for what might be causing them pain and let's deal with it. We want to observe their behaviors. We want to see if they're doing anything that might be we can attribute to a pain-related behavior. We're going to ask the family, like my other patient before, who just said, oh God, oh God, oh God. Let's get the family to tell us, how do they behave when they're in pain? They know them better than we do. Let's ask them what they normally do. And if we can't make any of that work and we think there's a strong possibility, let's try an analgesic trial. Let's see how that works. Let's see if that makes a difference to how they're behaving and makes a difference to their quality of life, or helps them in a way that we can see and move and touch. So therefore, we come back to a kind of slightly different working definition for pain in dementia, which is it's suffering associated with bodily injury or disease, characterized by physical and or emotional discomfort, which gives rise to a set of distinctive behaviors or perceived by caregivers as indicative of that discomfort. So they don't have to self-report. We can see things that allow us to say this person's in pain. I'm going to whiz on to management. This is the bit everyone always asks about. Now, I have to be clear, I am not a prescriber. I don't particularly want to be a prescriber. It gets very, very complicated with older people very quickly. So we're going to look at this. There are often delays in treatment for people with dementia receiving analgesia. And then when they do get prescribed them, they're often prescribed less and weaker versions than people without them. So the silver trauma patients with dementia got a third of the analgesia of those without dementia. And as I've just said, they're experiencing more pain for any given trauma if you've got Alzheimer's or vascular dementia, which are the most common ones. Even if they get a prescription for pain relief, it doesn't necessarily mean that they actually get it. And there's some studies, they found that up to 83% of the patients who are prescribed analgesia didn't actually receive it in the end. Now, we sometimes on our unit, where we deal with a lot of dementia and delirium patients, we have a fairly low tolerance for going for patch analgesia. There are issues with patch analgesia, but it's one way of ensuring that they do take their analgesia, because you can't not take your patch. But there are other ways around covert medication and things that can be sought if needed, if you run through it in the right way. Non-pharmacological management, well, exercise isn't effective in managing pain in older adults, and therefore it should be equally as effective for managing people living with dementia's pain. Depending on the origin of the pain, your approach could include repositioning, trying to find positions that ease the pain and more comfortable for the person, or some people will need positioning systems as they really progress through. They might need specialist seating or a specialist bed to support this. Massage can help. Hot and cold treatments can help. Human touch is a very powerful thing and can help. Relaxation therapies can help. TENS machines, as long as your patient's able to give you the feedback to be able to set it up, can help. Acupressure has been shown to help in some studies, and general human interaction, socialization, can help. All of us who've experienced pain will know that if you're kind of distracted from your pain, you don't notice it quite so much. So it does help. When you get into the pharmacological, the medical management, your aim is to try and get optimal pain relief whilst you're minimizing your dosing and reducing the risk of the side effects. So you want to use the least invasive route for your medication. You want to try and use sustained release formulations if you can. You want one agent at a time at a low dose and a slow titration upwards. And you want to know there's enough interval between changing a medication to know whether you've had an effect or not. Can't just keep whacking it up every day. You're kind of asking for trouble. Paracetamol, apparently that's a paracetamol molecule. Who knew? Drug of choice for mild pain. It is effective and it is safe. And it does also enhance the effect of opioids. So if you have an opioid, have paracetamol with it, it enhances the effect. There are some concerns about the damage it might do to your liver, especially in older people who are frail, and especially if it's administered intravenously for frail older people. And interestingly, there's been no studies looking at the literature that have looked at using paracetamol for 3 months or more. So it's a bit unknown after that point, although we often see people on it for a very long time. Non-steroidals, you will not see them often in older people. They should be prescribed with extreme caution. There's a lot of GI tract side effects. Again, safest route is topical. The NICE guidelines for OA knee are still, I believe, still recommending paracetamol and topical non-steroidals as kind of first line pain relief treatment for OA joint. Topical non-steroidals can be quite effective sometimes with people, especially if you think your pain is coming from a structure that's fairly superficial, then it can work quite well. Interestingly, we see a lot of people on compound analgesics, but the literature is not keen on them. They feel they increase the risk of side effects without a significant increase in pain relief. So they'd rather give them as 2 separate drugs that you can titrate rather than give one compound analgesic, which was interesting. Codeine on its own, they didn't find to be an effective analgesic, but it's more effective when given with the paracetamol. So paracetamol and codeine separately as a combination is a good combination generally. Now, this is where you get back to the delirium element. Opioids are commonly thought to cause delirium, but the evidence is all over the place on this. There is evidence to show that if you give a lot of morphine, then you're going to increase the incidence of delirium. But there's also evidence that if you're in severe pain, if you give lower dosed opiates, you're not treating the pain, you increase your delirium risk. So it's a bit of a balance between getting rid of the pain to reduce your delirium risk and giving too much opiate to give you a delirium risk. So the balance is somewhere in the middle, which is why I don't want to be a prescriber for older people, because it's quite tricky to work your way through. There was a double-blind trial of opioids which found a high risk of adverse events, which overlapped with the BPSD symptoms we were describing earlier. But in another trial, they found only 2% of patients who had opioids discontinued their opioids due to side effects, which is really quite low. But the evidence that's out there does suggest that opioids succeed in reducing pain, and the bits of evidence I've been able to go through are that oxycodone and morphine are better tolerated than most other opioids. And I know our pain team are quite keen on oxycodone as a management method. I'm getting there. I've had it where, so this was a quick description of saying that everybody is different, and their physical appearance. So little old lady gave us some opioids, nothing happened. She looked no different, still in so much pain. You can give them to a great big rugby player and it knocks him a spark out straight away, the same dose. So some people, everyone's different. Everyone responds differently to medication, which is why it has to be titrated and managed on a case-by-case, individual-by-individual patient. Quick word here. You need to give people regular pain relief. You might have some PRNs to help you titrate up the amount they take, but you need to give them PRNs, especially in advanced dementia. They're not going to request it verbally. They're not going to ask for it themselves. And if 40% of nurses are going to go around and see if they're in pain, if they're lying stock still, don't think they're in pain, they're not going to give it either. So regular prescription works better than PRN prescription. If we don't manage their acute pain, they're going to develop, well, be at risk of developing delirium, falls, delayed recovery, slow rehab, the bits we mentioned earlier on. They're going to come back and haunt us. Quick return to total pain. And now we'll just quickly pull it all together, and then I'll just about run over, but a little bit too much. So just to be really, really clear, people living with dementia do experience pain, unlike my registrar thought. Types of dementia influences the pain experience and your responses to pain. But the pain experience is often worse for the most common types of dementia. Pain can profoundly impact the quality of life for people living with dementia. And the evidence is that our pain assessment in the healthcare systems is currently inadequate, and that older people with dementia are being undertreated for their pain. So we need to go out there from today and make sure we make the best use of our self-report of pain from our patients. We include pain on activity, and we include the impact of pain on function when we're making our assessments and treating our patients. For the patients that we have, the people that we're working with are unable to self-report. The observational pain scales are out there. They're sensitive in detecting pain in people with dementia, but they've got like this high false positive rate and may actually detect behaviors caused by fear, frustration, or anger. So they determine the intensity of pain for people who are unable to self-report is very, very difficult. So we want to take that pragmatic approach we went through: self-report, search for pain, observe their behaviors, ask the family, involve the family in seeing what they think, and attempting an analgesic trial. We can use appropriate non-pharmacological treatments. We can try and help here. And we should regularly reassess to guide management, especially the analgesic trials. We need to work as a feedback tool for our medics to allow them to titrate that pain appropriately. But we should be using movement-invoked pain as an outcome for readiness to discharge from physio, and a key component of determining someone's ability to go home and cope. Thank you all for listening. I've only overrun a little tiny bit. I'm sorry I talked really quickly, but there was a lot to get through. So thank you for all coming and all listening, and I hope it's been useful for you.
Thank you so much, Adrian. It's been very informative. So the floor is now open to questions and comments. So there's been lots going on in the chat. I have failed to catch up, but Ritu has been kindly having a look. So Rachel will let us know of any questions there. So does anyone want to ask a question? Please, you can put your hand up and.
Yeah, I mean, I think there was a question from Helen. Helen, do you want to unmute and ask the question that you have put onto the chat?
Yes, is that me, Helen Hetherington?
Yes, it is.
I can hear you.
Yeah. Yeah, I was just asking. Sorry, I did it very last minute. I think there's a few more questions in before
Sorry.
me. But I was just wondering how it kind of works with you mentioned about covert pain relief for patients, and I just wondered if that would kind of depend on a capacity assessment or if they would need a DOLS in place.
Yeah,
if they were needing that sort of thing.
Yeah, you'd need a capacity assessment and you'd need a best interest decision that it's in their best interest to deliver it in that way. Within the acute hospital setting, it would form part of a DOLS. If they were in a residential home, nursing home setting, it would form part of a DOLS. I'm not sure about in their own home. So I know there are some people that do have covert medication policies in their own home, but I'm not sure if it forms. Someone who works in the community more than me might know, but I'm not sure if that has to be part of a kind of overall DOLS or whether it's just done as a MCA and then best interest decision to then go down that route as that's in their best interest to manage their medication in that way.
Right, because I work in the community in Sheffield, and I've not really ever seen sort of covert medication administration. Although you know, a lot of people have carers and they go in and they give them the medication, and I'm not entirely sure they know. So maybe that is a form of covert.
Maybe it's covert medication.
Covert minus DOLS.
It's probably doing the right thing with the right rationale behind it, but not necessarily with the formality of going through the process of delivering it in that way. In the kind of care settings, we absolutely need that formality of this is what we're going through. And I mean, we have had some families who object to covert medication. We've had LPAs that have objected to covert medications, and you know that's happened sometimes. And unless you can really be sure that this is utterly life-changing for them to not have that medication, then sometimes when you want to try an analgesia trial, it's hard to just 100% justify it. But I think most of the time we haven't had a problem with it as long as we run through that process of MCA and best interest decisions. So I know Rohan's got a hand up. Rohan?
Yeah.
I just wanted to say I think the covert administration issue with pain relief is a really difficult thing. So locally in our trust, we tend to have to if any covert administration usually has to go through the mental health nurses, the dementia team, and the psychiatrists that run there. Actually trying to get pain relief past them as a covert administration is nigh on impossible. It's almost never considered, unfortunately.
I would suggest then use a patch.
Yeah.
Butrans patch.
That's usually what we do.
Yeah, just go for the Butrans patch. We don't have similar problems, so it sounds like it's going to be different trust to trust. I'd love to know what their rationale behind that is, because covert medication, would have the same view if it was I don't know, anti-epileptics or whatever that they're taking. It's if it's to allow them to live a better life and you can demonstrate that it's in their best interests, I'd have thought that there's still a route through the MCA and best interest pathway if you can demonstrate that it's in their best interests to have that analgesia going in regularly. If they feel a better route is to go down patch analgesia, and that's less invasive, less disruptive, and can be delivered in that way, that's equally fine. It's not a problem as long as they're happy for you to get that analgesia in some way to make their life better, as far as I can see.
Thank you for that question. I think in terms of the community, I'm also a community physiotherapist, and I've not seen the covert medication in people's homes, like those who are still living in their homes, but in the care homes, I've seen a bit more of it. Claire?
Thanks. Just thanks a million, Adrian, for that presentation. It was really good. I find a lot in ED and our older persons assessment unit that this is a constant issue, is people are in with, you know, a humeral fracture and they're not even on a regular paracetamol, and they wonder why we can't discharge them home. We do have great consultants once they get on board, it's brilliant, but we find in that early stage, particularly in ED, people just aren't getting the pain relief they need, and we're the first ones to pick up on that. Do you have any suggestions on how to get the rest of the MDT involved?
I think the front door is quite challenging, and our team in our ED have very similar problems to the ones you're describing. I've seen cases over the years where you look at it and they're on like a whole list of analgesics at home. They come in with a fall and maybe a fracture, and they're saying they're in more pain now, and they're giving them less analgesia than they were getting at home, and they're wondering why they can't function. And you're like, what are you doing? I think there's a fear of giving opioids to old people at the front door because they fear they're going to tip them into a delirium and they're going to cause more problems.
Yeah.
There is a small risk of that, but if their pain is causing them a change in function, they've got to get on. I think it's going to be educational, and it's trying to get your frailty consultants, your geriatricians interested in frailty, almost into this sort of a presentation around pain management and what works and what doesn't into the front door system, and trying to say, look, you know, we're going to be able to get these patients in and out of your ED much quicker if you manage their pain appropriately. So the therapists have actually got a shot of returning them to some sort of function that's going to get them out of here. And once they begin to understand that it might be in the benefit of them to deliver these things, to get people through the system that bit quicker, it might begin to gain some traction. But I think it is quite a slow process. There was an interesting article, I think it was in Age and Aging fairly recently, about using nebulized ketamine at the front door in ED to reduce acute pain, and it had less analgesia, less side effects than opioids. But my colleagues, geriatricians, took one look and went, there's no way we're giving ketamine.
No.
Oh, is not going to happen. So yeah, there are people working on kind of almost acute management pathways. But if those doctors would have given X painkiller to a 45-year-old with that humeral fracture, why not look at the same thing for the person you have with a cognitive impairment? Because let's be fair here, they're going to feel it just as much, if not more, is what the evidence says. And I think we've just got to keep educating and try. I do this talk to doctors at our trust as well, and I get shocked responses a lot of the time. So yeah.
Brilliant. Thank you.
Thank you. I've just put in the chat that I think there's also the fear of the patient becoming drowsy from some of the medication, and then because of the dementia, then they are likely to keep trying to walk, and then that increases their risk of falling.
There's always that risk when you introduce something new, and that's why it's always that start low, go slow process of introducing it at a lower level and then building up. There is always a risk when you're introducing, especially opioids, that you will get people may become drowsy. They may have a bad reaction to it. The same is true of younger patients as well. And I think it's just that monitoring that needs to go on and that constant reassessment. Opioids can be reversed. If they do become very, very, very drowsy, they can give Narcan and just reverse it. It's, you can reverse the effects of opioids if you end up going down that route. It's the other big concern older people have generally about taking analgesia is it will make me constipated. And you constantly hear, oh, I'm not taking anything stronger, it will make me constipated, and then they can't actually function because they're still in pain. And the answer is we've got lots of things we can treat constipation with. We can give you lots of things to keep you going. And if any geriatricians that will be prescribing tend to prescribe laxatives alongside stronger and stronger pain relief because of that very reason. You don't want people to get constipated. It tends to make your pain worse. It again will make you delirious. We don't want them to get constipated, but we do want to try and manage their pain. I think it is trying to just slowly work your way up into that pain relief. We have had people that we've over-treated and we've had to back off because they become too drowsy and a bit too dopey on too much analgesia. And then you have some people where you're trying to balance that drowsiness with the pain relief, and you're trying to find that sweet spot between being a bit dopey and not having a lot of pain, between, or being wide awake and being in lots and lots of pain, or being too sleepy and being completely pain free potentially, but being too sleepy. So it is a balancing act. It is a juggling act, and it isn't easy. Is the long answer I've given.
Thank you so much, Adrian. Ritu, is there anything else?
No, I think
it's
in general, there were a lot of comments, and a lot of the topics that you covered in the presentation, there was an agreement from a lot of the participants of experiencing the kind of experiences that you were sharing. But I think in terms of the questions, most of them were comments. So if there is anything that has not been answered, because we have hit 8 o'clock, if there is anything that has not been answered, then maybe we can get back to the participant and
Try and do that. Yeah, no problem.
thank you.
perfect. Thank you so much, everyone, for being here.
Thank you.
Yeah, thanks, Adrian, for that presentation. We've learned so much. And yeah, you've got us thinking about dementia and pain and how to support our patients and our colleagues as well. Ritu, thank you so much for your support. Everyone, Ritu is the co-chair. She co-chairs with me the Agile East Committee, and you'll be excited to know that Adrian is also a member of the Agile East Committee. So we are open to more members joining us. So if you would like to join our committee, please do join us. If you have any question that you've not been able to ask, please, you can email us on agileeast@gmail.com. I'm putting it in the chat quickly. Otherwise, the slides will be coming to you. They might not be exactly the same, but whatever Adrian agrees to will be coming to you. And also you will be getting a certificate for those who are interested for your CPD portfolio. And then also the recording will be put on our YouTube channel, and someone has put the link in the chat. So thank you so much for being here. And if you have any topics you would like us to bring, if you have speakers that you would like us to bring to you as well, please do drop us an email and we will try and organize more of these talks. Thank you so much and all the best.
Thank you. Thanks for coming. Thank you.
Thank you.
Oh, Dawn. Do you want to ask Dawn?
Yeah. Dawn, do you have a question?
Thank you. Thanks, Helen.
Shall we stop the recording, please?